within the community, if you're feeling as if you're not supported, if you're feeling that you're being bullied, then where is the person that I go to? Where is my voice? Where's the person that's going to stand up and actually understand me? Who has demonstrated the ability to hold what I have to say and affirm what it is that I believe, and also to help them to know that this is going to get better. So that is, stigma is a huge barrier.
Welcome to the APA More Equity series, Breaking the Silence, Addressing Youth Suicide. In this episode, Dr. Pratik Bahekar is joined by Dr. Melvin Oatis. Dr. Bahekar is an assistant professor of psychiatry at Yale University and a fellow of the American Psychiatric Association. He completed the general psychiatry residency training program at SUNY Downstate Medical Center and Yale University, as well as a forensic psychiatry fellowship at the University of Pennsylvania. He is an acute inpatient psychiatrist at Yale Psychiatric Hospital, where he provides clinical care to young adults, and geriatric patients. His focus is on advancing LGBTQ+ mental health, and he has participated in advocacy and policy development efforts. He serves as the president of the Caucus of LGBTQ+ psychiatrists for the American Psychiatric Association, as well as the president of the Association of LGBTQ+ psychiatrists. So now, let's break the silence with Dr. Bahekar and Dr. Otis.
Dr. Otis, it's a pleasure to have an opportunity to talk to you. Thank you for taking time out from your busy schedule to talk about suicidality in LGBTQ+ youth. So Dr. Otis is an adult, child, and adolescent psychiatrist in private practice in the New York City. After completing his combined residency training in pediatric medicine, adult, child, and adolescent psychiatry at Mount Sinai Hospital in New York, he joined the faculty of New York University Medical Center as an integral member of the clinical trial research team studying ADHD and comorbidities of ODD and anxiety. Dr. Otis remains a voluntary faculty at the NYU Grossman Child Study Center. Dr. Otis is a current co-chair of Advocacy Committee of the American Academy of Child and Adolescent Psychiatry, and also serves on ACAP Presidential Task Force. Welcome again.
Thank you for having me here today.
Our pleasure. To begin, can you share what first drew you towards child and adolescent psychiatry, particularly in focusing on LGBTQ+ youth?
Sure. So I always wanted to be in medicine, and pediatrics was the first entry into it, and then child psychiatry. And at Mount Sinai, we had every type of population known to man, and then that continued while at NYU. And in my private practice, I get referred just a lot of people throughout the city and the surrounding area. And increasingly, I think children are more in touch with mental health care, or more in touch with seeking help and talk to their parents about it. And increasingly, you see anything in terms of like television, movies, have things regarding mental health in them. So we're seeing more children in that arena. And also, as you probably well know, that the LGBTQA community has increases in mental health referrals and increase in mental health challenges as well. So with all that, it's been an honor to be able to serve the community.
Absolutely right. What is it important to have focused conversation about suicide risk, specifically within LGBTQ+ youth populations?
Having focused conversations about suicide is extremely important in the LGBTQTA community, primarily because they are at increased risk for suicidal ideation. So it is not that it's so common, but it is not uncommon for children and adolescents to talk about suicidal ideation. And oftentimes they're terrified at that thought, but they're also challenged with who to tell that to. How can they trust somebody with that? What will they do with that information? So it's really important to have a real direct conversation in terms of having them understand what that is, having them understand that it's important for getting help, for getting treatment, and that is absolutely normal to talk about it.
Why suicide rates are high amongst LGBTQ plus youth compared to their cisgender heterosexual counterparts?
Well, there are a number of factors that contribute to an increase. First, just adolescence itself is a vulnerable time, as you well know. The brain is developing until age 25. So with that, and through puberty, you get this surge of hormones, and everyone responds to that differently. They get different desires that are going on within their body because of that, and the challenges with that, and how often is that talked about? Maybe they hear a little bit something about it in health. May have had one conversation about birds and the bees with their parents, but it's pretty limited regarding what else they talk about around the mental health or emotional well-being. So, and not only that, bullying is common to LGBTQ individuals. So, I mean, that happens in the schoolyard anyway, but this is also another point of vulnerability. So that increases the incidence of suicidal ideation. Also, just within a community, I'm not talking about just like your community, your neighborhood, but your community at home, your community in your school. What is the community with your friend group? How often is emotional well-being talked about in that population or any kind of way with that? So you have vulnerability because of just development, you have vulnerability because of bullying, and also increasingly because there is an exposure with kids having their phone, there is social media, right? So there's an element, well, social media can be wonderful in terms of connectivity people, but it can also be a ways in which people are bullied as well, quite broadly. And so in a vulnerable population, not really understanding all of these different variables, that can lend itself to also increases in suicidal ideation.
According to CDC's Youth Risk Behavioral Survey, LGBTQ plus students are more likely to misuse substances and experience multiple forms of violence. How are these experiences interconnected? And what impact do they have on suicide risk?
So let's step back and say that youth in general experiment or have some curiosity about various substances. So just the vulnerable population of being an adolescent, children are going to think about different substances and have exposure to different substances. But when you're already having some other challenges, you're already having other environmental threats and things of that nature, that can also increase the incidence of wanting to try something or escape the way in which people are thinking, right? And if you want to add to that, if people are teasing or bullying in these things, that can also increase the susceptibility for this group of youth to try substances. So if you want to add just the vulnerable population and then add on a use of a substance, you're going to increase the chances of suicidal ideation. You're going to increase impulsivity. You're going to increase the cloudiness of thinking. So that also is making this population a bit more vulnerable when you add that in.
Can you speak to the intersection identity of how race, gender identity, and socioeconomic status may compound risk for LGBTQ plus youth?
Ooh, well, that's a big question, right? In
Right.
terms of gender. So, just in talking about gender, I think there's a challenge from a perspective of gender roles, gender identity, of whether or not a child is gender conforming and non-conforming, and what that looks like. And then what does that look like within their community at home? Do their parents support their gender expression, as it were? What happens when the child goes to school in terms of their gender expression? Do the students around them support that? Does the teacher or the principal, what happens in that environment for that child? So all of these things are important in terms of the intersectionality there when we start with gender. Then we want to start with, I think you said socioeconomic status. So we're talking about social determinants of health. Anytime you're talking about social determinants of health, vulnerable populations, LGBTQA population, uh, communities of color. These are all added factors that are going to play a part or play a role in emotional well-being. So you have all of these challenges that intersect, and then you want to think about what are the resources for a child to then be able to discuss these types of things. So all of these things are playing a role in their emotional well-being.
More than 60% of LGBTQ plus students report persistent feeling of sadness or hopelessness. What does persistent emotional distress look like in clinical terms? And when should we be especially concerned?
So, in looking at emotional well-being or looking at distress, that's going to play out very differently. We can't fool ourselves to say it only looks like this. But notably, we look for changes, right? If there's a change in someone's affect, a change in their mental um, expression that you can account for by, if they're not able to put a label in it or talk about what is accounting for that, that should arise suspicion, right, for the community, for the people that are that have to take care of this youth. So any sort of change in behavior, if there's any sort of sadness, so we all have experienced periods of sadness, but there may be this period of sadness that you exhibit that goes away a little bit and gets better. But if you have a persistent sadness and you can't really identify a factor, that should be something that's also explored. I think the challenge with this is that the kid doesn't know how to necessarily express that, and we could invariably label them incorrectly and just like, that's just adolescence. That's just adolescence. They're moody. And I want to caution parents that, okay, yes, there are adolescents that are moody, but if there's a change from their baseline moodiness that you guys have established in terms of thinking about them, then there's something more that you should explore. You should ask them about that. Is there anything that they'd like to tell you about? Is there anything that has happened to them? And you really want to approach this in a very non-judgmental, supportive manner. Now, parents and teachers can think that that is what they're doing, but the perception of that can be quite different. And if someone is having some persistent sadness, that's also a challenge, because then that lends them perhaps to being a little bit more sensitive to what's being said to them. So you have a myriad of challenges. Someone that's having some persistent sadness. Then on the other side is, how do you explore that? How do you get to talk about it? How does someone avail themselves to that sort of help?
From your clinical experience, what are the long-term consequences when young people are left to carry out the level of sadness and hopelessness without support?
Long-term consequences of kids not getting support. Is that the question, in terms of if they have some
Right.
persistent sadness? So just their developmental task, the task of where they are, of being in school and managing their grades in school, the task of being social and making friends is a challenge for them. Just completing their daily task and homework, that's also going to be problematic for them in terms of showing up. But a real challenge also is even trying to express what's going on. If you're seeing that with your children, you really don't want to write that off, right? You really don't want to just say, that's typical, that's normal. You really want to have a chance to sort of explore that a bit more, slow down a bit more, and really try and understand what that is, because that can lead to school failure. It can also make one more susceptible to trying to escape that sort of feeling, as you mentioned before, with substances. And we are talking about the topic of suicide. So someone can want to escape that and have suicidal ideation and be fearful of being able to express that, or not knowing how to talk about that, or feeling a bit of shame around that. So again, the supportive, calm way in which you approach the adolescence is extremely important in talking about suicidal ideation.
Can you tell us more about some early warning signs to clinicians, parents, or educators should look for when an LGBTQ plus youth may be at risk?
So early signs, again, I go back to change. If there's any kind of a change from their baseline, if there's a persistent, we think that a change in behavior is going to look like sadness, but sometimes it's irritability. Sometimes it's mad. They're just talking about they're mad, they're angry, and they don't have a reason for being mad or angry. Or sometimes it may be a somatic complaint. It might be said that they have persistent headaches or persistent pain, persistent stomach aches, or anxiety or fears that are somewhat unfounded and they can't explain it. So there are a number of ways in which it may not just look like sadness. It might look like anger, and it may just look like really low grade energy and inability to do things, or persistence in saying that they're tired. Now, we'd like for them to be able, when we go down our DSM 5 and ask about hopelessness and things of that nature, but that may not be the word in which they're able to identify or talk about. So it might just be tiredness, anger, and irritability may be something that the child is talking about, or in sort of like abdicating their responsibilities, fleeing their responsibilities, or not wanting to be around their loved ones and really isolating. So in this day and age where children have their own phones, their own televisions, and things in which they can be sort of by themselves to their rooms, we want parents and we want caregivers to be involved and know that, and not allow them to self-isolate. So besides the emotional things, the self-isolation could be one of the other things in which we're looking for.
From a psychiatric perspective, what types of support or therapeutic approaches are most effective for LGBTQ plus youth in crisis?
Okay, so the support can take the form of talk, of just hearing someone, sort of supporting them and giving them information that affirms what they're feeling. Also, there could also be a point of giving them information about what they can do to feel better, what sorts of activities, other ways in which they can engage. But if that isn't enough, there are other forms of therapy. Cognitive behavioral therapy is quite useful in terms of having them reframe their thoughts, what's going on with them. Also, DBT, dialectical behavioral therapy, is also useful. When kids are having some of these challenges, sometimes they feel as if no one can understand them, or sometimes because of their personalities, they can get really locked in on a way in which they're feeling about something, and again, saying no one understands them. But by these methods of both supportive therapies, cognitive behavioral therapy, dialectical behavioral therapy, DBT kinds of things, are ways in which we can help the individual. Sometimes those things aren't enough, and in crisis, some children may have to be brought to the hospital. Some children may have to be hospitalized for a while. That's going to vary depending upon the person. Sometimes if we get before that and we're doing therapy, sometimes therapy along with medication is something that is needed. But the challenge with all that is seeking a mental health provider, and also ideas about medication, and then that opens up a whole other arena of discussions for family when we're talking about therapy and medications.
How can psychiatrists or health professionals in general make their practices more affirming and safer for LGBTQ plus young people?
When you're doing your initial assessment and when you're talking with your families, you want to be as general and open as possible. When we're asking things about attractions, we really want to allow people to understand that we are able to hear anything that they're able to say us. Tell us about attraction, be it male, female, both, and in the most non-judgmental, even way possible. If we have to practice that for a while to be able to do it every time, then that's what we need to do in order to let the youth that come into our office know that we are welcoming to them. We should also be able to talk with their parents, talk with the child and the parent together, but also talk to the parent and the child separately, because in that we can get a sense of whether or not this child feels supported, or what the real ideas that their parents and their community have about perhaps their gender expression or their sexuality. And then when we're talking with the parents, doing the same and trying to understand how have they tried to be supportive or understand their child. When you were talking about some of the intersectionality and challenges before, what I didn't mention is in different communities, different communities of color and LGBTQA, there's certain people may share a faith or not share their parents' faith, or people may have attitudes around that. That may be something that we really have to talk about, or that may be a challenge for the parent and child to be able to have a conversation based upon whatever their faith or religious upbringings are. Sometimes that's a challenge, and that has to be talked about quite directly. Sometimes there may be some differences in them that may not mean very much to them. So we have to understand, what does it mean for the child? What does it mean for the parent? And have those very direct conversations. But also really affirm in your first meeting that you are there for support, that you can hear anything that they have to say, that it's rare that anyone's going to say something that you haven't heard before, and that you're going to do your best to be both supportive and to keep them safe.
Talking about families, what role does a family acceptance or rejection play in suicide risk? And what can families do to do better, even if they are struggling to understand?
Now, so that's going to vary from child to child, because you can have a parent that thinks that they're being very supportive, but the child doesn't perceive it that way, right? In terms of what that parent is offering. So the level of support is critical. It is absolutely essential. A big fear that still exists is if the child tells their parent and caregiver that that they're questioning, or that they feel that they're gay or bisexual, anything that isn't quote unquote heteronormative, that might be a challenge for them and a reason for them to leave their household. And that may be the fear. And maybe that isn't actually accurate, but that is a fear that can prevent children from actually having a conversation with their parents. So it's absolutely essential for you as the clinician, as a physician, as a provider, to have conversations with their parents and have an understanding. If it's in their culture, if it's in their background, that this is a challenge, explore why that is a challenge. But also, I don't think there's a family that doesn't love their child, even if they have differences or don't understand their development. I think there are times where the parents really just does not understand their lack of support or their appearing rejection, how strong an impact that can have upon a child. So that requires some individual work for the clinician to really explain that. So support is essential. And while you're trying to build up the parents in order to be supportive, on the other side of that is talking with a child to have them have other adults in their life that can be supportive. Maybe they don't feel that they can have this conversation with their parent. We will always want to encourage them to do so, but maybe it's going to be an aunt, an uncle, a grandparent, a godparent, or some other adult that is a part of the caregiving circle, a village of that child, that the child can feel a level of support and understanding and go to. So that's going to be extremely important. If it's not the parent, if it's not the grandparent, if it's not the aunt, uncle, what is the adult? Where is the community? What is uplifting, surrounding, and a safety net for that child?
Well, you mentioned community. Are there any evidence-based school or community programs that have shown to reduce suicide risk for LGBTQ plus youth?
Yes, support for youth is tantamount for their survival, for their ability to get help. There are a number, like you mentioned at the beginning of this, there's surveys, there's the Trevor Project, there is Dan Savage had It Gets Better, there is the American Foundation for Suicide Prevention, there is the NIH websites, their government websites that all give a number of resources and also show that these sorts of interventions are helpful and protective of youth. Not only do you have those broad ones that I just mentioned, but you also have community organizations like NAMI, the National Association of Mental Health. That helps. So you have NAMI, you have PFLAG as well as another resource within the community. Increasingly, even the faith-based organizations have mental health counselors. You have some pastors, rabbi, ministers that also have some background in counseling or some background in helping people with emotional well-being. So increasingly, there are other ways in which people can receive assistance rather than just getting to a psychiatrist, because most people aren't going to run right out to the adult or child psychiatrist. Even their pediatrician or their family GP might be also a source of support. So everyone at this point needs to have some sort of training and understanding in terms of mental health and well-being, and talking about this and really talking directly about suicidal ideation and taking sort of that sting out of it, trying to decrease the stigma so you can talk about this. So I'm talking about a support, but as I'm thinking about this, I'm also thinking about the barriers that stigma still exist. As much as I said earlier that children are coming into the office a lot more savvy and a lot more welcome to interventions and able to talk to their parents about that, there's still stigma involved depending upon the community. Definitely wealthier, educated communities get a lot more exposure to mental health and emotional well-being than other communities, but it is possible. And for that matter, whatever culture you find yourself in, whatever that institution, maybe in the Black community, that might be a church, that might be a community center, that might be the barbershop, it might be the nail salon, where people are talking about this. And there are studies that help within the community is very, very useful in terms of prevention and really surrounding the child with a safety net.
Talking about barriers, what are the biggest systemic barriers that prevent LGBTQ plus youth from accessing timely and affirming mental health care?
Well, a lot of it is fear and a mistrust. And if within the community, if you're feeling as if you're not supported, if you're feeling that you're being bullied, then where is the person that I go to? Where is my voice? Where's the person that's going to stand up and actually understand me? Who has demonstrated the ability to hold what I have to say and affirm what it is that I believe, and also to help them to know that this is going to get better. So that is, stigma is a huge barrier. Even cost, right? In terms of, you have kids that feel as if what they're going through, that they are a burden to their parents or a cost to their parents if their parents are having some financial challenges. That could be something else that's within this child's mind, where they're not really thinking so much about themselves, but they are feeling badly about themselves, but also feeling burdened that they have these challenges. And so we really want people to understand that to give the message that you are not a burden in any way to your family. You're not a burden to your community. Your community can be helpful to you, because with time, you are going to be an asset, and you're an asset right now to your community. So mistrust, stigma, cost are all challenges. Fear is a huge challenge and a huge barrier to happening that. Also within the healthcare environment, having people that look like them, having people that they feel were going to understand them for culture. We spoke of cultural competence, cultural humility, and all of these things are important. That's not to say that someone can't help an individual that doesn't look like them, but they have to be able to listen and hold what it is that the person is telling them in order to be able to help them. So increasingly, we need more people within the community that looks like the diversity that is within the community. We need caregivers that equal that as well, so that we can give people the care that they need.
How do peer support and chosen family factor into building protective networks for LGBTQ mental health
Right.
youth?
So happy you asked that. So that's a wonderful support. If you can't get what it is, or if the child is not getting what they need or feel that they can get it from their parents, their peers, they're a peer that's the same age that has supports in other arenas can help them in terms of support. Peers that might be older or younger can also provide support. And the notion of chosen family is a very strong one, and something that has really shown to be effective. So when a kid is feeling bad and they're feeling suicidal or just feeling really hopeless, it's really hard, right, for them to reach out to that community or reach out to someone else. So it's incumbent upon us all to to be able to circle around and help all the children. Within the American Academy of Child and Psychiatry, where I am, the presidential theme is one of bringing the village to the children. So when we are seeing people that are in need or hurting, we need to get to them. Because sometimes it's hard for them to come to us. So that might look like the physicians, it might look like the neighbor next door, it may be the principal of the school, it might be a counselor, what have you. It may not be the direct blood relative that is the person that is providing the most support. We want to get them, and that's crucial, as I mentioned earlier, but it might be other people outside the family that are providing that support.
In your opinion, what policy or funding changes would make the greatest difference in suicide prevention efforts in the community?
Well,
That's a power.
not cutting Medicaid, having students paying back student grants, student loans, so that people can remain within the educational system in order to spend enough time to become fully trained to take care of people. So prioritizing mental health along with physical health, parity laws, the enforcement of parity laws so that people can receive care and it's paid for. So many people have to go out of pocket for both adult and child mental health care, but it should be right up there with everything else because mental health care is health care. It is for you to be completely sound and well and to be able to do everything. Everything needs to be functioning. So the laws that enforce parity, the laws that help to have a diverse workforce, the laws that do not cut Medicaid and things of that nature, and also funding to community organizations. Oftentimes there's a dearth of resources where they're needed the most. Our large institutions are fine, that's wonderful if you can get there to get your care, but more often than not, LGBTQA and patients of various ethnic minorities are not necessarily in those areas. So care, laws, money, resources that go to the community will help to make a big difference here.
What gives you hope when you're working with LGBTQ plus youth, even in face of such heartbreaking statistics?
Oh, hope is actually having them in the office and seeing that change, having them feel supported, really when they say that they feel supported, when they are able to talk about a difference, and that the power of them feeling different, that they also want to go out and help their community. They want to help others that feel like they do. So the help is when you see that change, it gives me hope. The fact that children and youth are resilient also give me hope. But we have to normalize being able to talk about this very directly. We also have to have the youth understand that they're not alone. We also have to let them understand that it does get better, that this is part of development, and that it's not a one size fits all. This may take longer than they want to just like spring out of it, but the thing that gives me hope is seeing that change and then being able to verbalize that and then them wanting to then help others to get better too.
Dr. Otis, thank you for your informative conversation and your contribution towards advancement of LGBTQ mental health. It's been a pleasure talking to you. Before we go, can you tell us the one message you wish every LGBTQ plus individual, especially youth struggling with their mental health, should hear right now?
They are not alone in their struggles. They are not alone in getting better, that there is a community around them. If they haven't felt that community at their home, knock on another door at school, knock on talk to another friend, tell people how you're feeling, and know that this can change for the better, and not to have any sort of fear or care around around stigma around this. Normalize knowing that it's okay not to feel so great, and that you can get the help to feel better.
Can't agree with you more. Thank you, Dr. Otis. Hope to speak with you again very soon.
Thank you.
Thank you for joining us on Breaking the Silence, addressing youth suicide. Please visit the Medical Mind Podcast homepage at psychiatry.org for more information and a resource document related to this episode. We also invite you to visit psychiatry.org/moreequity, MOOREQUITY, for more information on the APA More Equity in Mental Health Initiative. Take care.
The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you are having a medical emergency, please contact your local emergency response number.